Hi, everyone. My name is Rebecca Robbins. I'm so excited to be with you today and share a little bit about my research. By way of introduction, I'm an assistant professor of medicine at Harvard Medical School, not too far away from you all, an associate sleep scientist at the Brigham and Women's Hospital. And for those of you who don't know me, my background and training are all in the areas of health communication and health marketing. So the kind of crux of my research program is understanding how patients, people, populations make sense of either sleep kind of behavior broadly or sleep disorder specifically, the diagnosis or the need to get treatment or evaluation, and then kind of building from that, designing interventions that then can support individuals and nudge and navigate them towards either better sleep health broadly or sleep disorders care. A lot of my work also does apply those tools to vulnerable populations, and we'll be talking about that a little bit today. So let's dive in. This is a disclosure form from the Yale School of Medicine outlining several of my conflicts of interest that do not have any relevance to today's lecture, but nevertheless, these are them. All right, our learning objectives for today are first to identify the threats to sleep health in our information environment, what the kind of sleep infosphere looks like online and how that matters for our efforts to promote sleep health in patients and communities. Second, how to apply tools from my kind of area of expertise, which is health communication and health marketing in order to design clear and hopefully understandable and actionable sleep health messaging and interventions. And third, I'll tell you one case history from some results hot off the press from my K Award, applying these tools and techniques to promote sleep apnea awareness in a shift worker population. So let's dive in. The first learning objective is to understand the threats to sleep health in our information environment. I kind of affectionately refer to this as our sleep infosphere, and we'll talk about what that is in just a moment. But first, broadly speaking, we do have kind of an information challenge in our society, and that many adults in America don't have the tools and techniques or the fundamental ability to understand and act on health information. About 36% of adults in the US demonstrate low levels of health literacy. So we have enormous, an enormous need to better promote our general population, their ability and their belief in their ability to understand and act on health information. Another kind of related trend, just to support the lecture today, is this increasing trend among adults in the US to leverage the internet in seeking information, attempting to solve problems related to their health. This was published in 2017 or 2018, so I wouldn't be surprised if this is much higher, but it's research funded by the NCI, and this found that 75% of adults in the US report that the internet is the first place they start when seeking health information. Now, that could be viewed as a positive trend in a lot of ways, but then the next question becomes, what resources are they accessing on the internet? Of course, and we'll touch on that in a moment. But before we do, this is happening in the sleep world as well. Perhaps you saw this paper. It was published by some of my colleagues here at the Brigham, Stuart Kwan and others, and they looked at Google Trends and they found a marked increase in searches for insomnia across the globe amidst the COVID-19 pandemic. And then in the United States, that same increase in insomnia and also sleep apnea, and again, overwhelmingly positive on some level, that these trends are happening, that people are seeking resources to better themselves. Now, related to this also is kind of in the midst of COVID-19 and in the wake of it now, this is a question, the wording was specifically, since before the pandemic, I'm now either educating myself more or less about health. So this information seeking trend is continuing. 40% of adults reported that they were seeking more information and in an effort to better educate themselves about their health. Now, the question, of course, then becomes, this question of what information are individuals availing themselves of online? And there is a wealth, there's no shortage of information on social media specifically. And the rates of media consumption on these channels are quite astounding. To put some numbers behind that, Snapchat posts on this platform, and by the way, these are not daily numbers, they are minute by minute volumes of social media content that's developed, some of which is health related, not all, but on Snapchat, about 500,000 Snapchat photos are posted per minute per day, which is just astounding. 4.1 million videos are watched per minute. It just blows my mind. And then 500,000 tweets or X posts. Still not sure what we're calling this platform, but about 500,000 tweets are posted every moment, and photos on Instagram, about 50,000, and 16,000 TikToks are posted. So just an enormous amount of content. And increasingly, a lot of this is health related and a resource that people are reaching to, in some cases, as their first step in their journey to gain more information about sleep or maybe a sleep disorder. Now, something that really kind of blew my mind recently is a statistic from the Edelman Trust, and this was published in 2023. And the question that was asked on the questionnaire was, "Who do you trust to tell you the truth about health issues, and how best to protect the public, the health of the public?" And fortunately, doctors were reported by 80% of individuals, respondents to the survey, as the person they trust the most to tell them the truth and to give them information, and to best protect the public, the health of our public. Nurses were not too far behind. And this is just what's so interesting. So health experts and scientists were below everyone else, not markedly so, but friends or family were reported to be an enormous source of, or people reported to put an enormous amount of trust in friends or family. And I think this just shines a light on how individuals in the general population rely on informal sources of health information, when sometimes the stakes could be quite large, whether to vaccinate or not, or get treatment or not. So something to kind of contextualize our conversation today about behavioral interventions that might aim to support individuals in their health and sleep health. Now, another related statistic, this was from the same group, and they found another kind of shocking statistic that 44% of Americans, there's a slight difference, or there is a difference between age group, but the question on this, the wording of this question was that the average person, or sorry, do you believe that the average person knows as much as a medical doctor? Yes or no? And 44% of individuals in the 18 to 34 range reported that an average person, they did endorse that belief, that an average person who's done their research is just as knowledgeable as on health matters as doctors. So that's pretty astounding. And if you look at just how high that number is in this age range, it goes down in older age ranges, but it just really kind of puts a spotlight on how in the medical profession we're often competing with sources that might not be credible, but are highly trusted. So just kind of an interesting statistic there to, again, tee up the conversation. Now, in the midst, or kind of all of these other forces, there's also a rise in misinformation. You've probably read these headlines in the midst of COVID-19, the rise of health misinformation specifically. The graph here is the result of a systematic review of studies that evaluated health-related social media posts in different health domains. The posts that they looked at, they categorized in one of several categories: vaccine research or posts, drugs or smoking issues, non-communicable disease, pandemics, eating disorders, and medical treatments. And they quantified the amount of misinformation in those different domains. Maybe not surprisingly, vaccines were the biggest culprit. So the most social media posts with the highest levels of misinformation were in that domain. And then kind of in a stepwise fashion, drugs, non-communicable diseases, et cetera. But really, again, just shows how we have kind of a tall battle to cut through a lot of this noise. And in this case, misinformation to reach individuals who need our information as sleep professionals. Now, my group and I were curious if this was happening in the field of sleep, this kind of proliferation of misinformation online. So what we did to look into this, we did a kind of a content analysis of the most popular videos on YouTube. As you saw before, just a channel that a huge number of people are relying now on increasingly for health information broadly, and as a study found, sleep information specifically. We entered into the search bar on YouTube the word sleep quite simply, and then we sorted by the number of views that each video had received so that we can then analyze the most widely viewed videos about sleep. And encouragingly, there was a new feature on YouTube that was just released when we started the study. You might recognize a dear colleague. I'm sure many of you know Dr. Eric Zhao as well. His video popped up on top of our search results, and this is a new feature on YouTube that returns a health professional if you search for any health-related terms in your search bar, no matter the filter or the sorting that you request, that health professional will come up on top. So, so that was encouraging. But then there were largely influencers and content creators that followed that health professional. So that was the good news. But then again, these individuals were kind of, oh, a TED Talk, of course, credible, but these two individuals were influencers and not necessarily with sleep expertise, as you'll see. So from this process, we identified 21 of the most widely viewed videos from non-health professionals. So that was the not the videos that returned, of course, in that top bar there, and 5 videos from health professionals that were returned using that new YouTube feature. Next, we assess the clarity of videos using 2 evidence-based health communication metrics. The first is called the PMAT. It's a resource from the AHRQ, and the Discern tool for information quality. So we administered those 2 questionnaires to each of the videos, and then we had sleep medical professionals and specialists coding presence of misinformation. We also coded the presence of a commercial bias. So if someone was one of the influencers was trying to sell products, for instance, that would be categorized as the presence of commercial bias within that video. What we found is that the videos of the non-health professionals, in other words, the content creators, the content creators and the like, far exceeded the number of views of those videos, far exceeded those of the health professional videos. So the influencer videos received 8.2 million views on average, and the health professionals just below 500,000 views. Now, the level of misinformation increased with the number of, or was associated with the presence of misinformation. So videos that had no misinformation had far fewer views. The number of views is here on the y-axis, and the level of misinformation on the x. The videos with a little misinformation were extremely widely used, well over a million views here, and then a lot of misinformation. These were kind of concerning levels of misinformation. One video talked about a magical sleep button on your forehead. It's almost comical, some of the things that we found, but those were also widely viewed and increased. The levels of misinformation did increase with the numbers of views, kind of lending to this idea that more controversial, less science-backed information is more likely to spread online. We also found 66% of the videos in the non-health professional category had commercial bias. So some of the content creators were trying to sell you a product. Maybe they'd give you a sleep health recommendation and then offer a link, like a referral link to a product. Tart cherry juice, I think, was one of the products that was featured. Now, the misinformation we found in these videos varying by speaker type. Not surprisingly, we found 0 misinformation in the sleep expert, the health professional videos. That's all the way on the right-hand side here. And then the other types of individuals that were on YouTube and had popular, widely viewed videos about sleep fell into 3 categories: bloggers, health coaches or fitness instructors, and medical professionals that were unrelated to sleep. The health coach and fitness instructors actually had the highest levels of misinformation, but all of these different categories featured either a little or a lot of misinformation in the video. So to combat this, we as sleep professionals can get together and create credible resources, right? And send them out to our audiences. Of course, that is a really valiant goal and something, of course, we strive for. But one of the challenges is health professionals and medical providers were trained to speak in sometimes jargon and from our medical training and communicate our findings in journals. So that doesn't always lend itself to clear communication that patients can act on. So with some colleagues, Susie Burditch here and some others at the Brigham, we kind of went about exploring the available OSA resources from credible sources, largely health professionals and professional societies of pulmonologists and sleep experts. And we coded the clarity and the understandability of the resources that we found. We identified a number of resources by asking patients and providers to report the resources that they access for information about OSA. So it was several patients, and basically we said, what are the resources that you use to kind of understand sleep apnea, and how did you kind of start your journey to sleep apnea care? So from those interviews and focus groups, we identified a number of resources that we then put through these batteries of kind of evaluating the clarity, actionability, and usability of the resources that we found. This is a publication the results of this were published in ATS Scholar. Now, the 3 resources in 3 different domains, because we heard from our patients and our providers that video resources, websites, and flyers were commonly used. Sleep apnea resources and available online. The top scoring video, website, and flyer are posted here. The top scoring video that from all of our batteries assessing clarity and understandability was a resource from the Mayo Clinic. Another website was from what is this? I think it's a ResMed resource, I believe. We'll see in just a moment. And then the top scoring flyer was informational resource from the ATS. So the results of our analysis of the clarity, that's according to the Clear Communication Index, a resource from the CDC, the PMAT, that's that AHRQ resource I mentioned before that assesses understandability and actionability. There are 2 domains. And then we can measure the literacy or the reading level of the resource. So even though these were the top scoring resources by video, website, and flyer here on the screen, they underperformed in terms of the standards on almost all of these metrics of clarity, understandability, and literacy. So in the CCI, 80 is this battery is the threshold for clarity, clarity of health materials. And none of these resources that were even the top scoring for OSA information met that threshold. Resources did okay on the PMAT understandability and actionability metrics, but the literacy levels were far more than is recommended of all of these top scoring resources. So the bottom line here is, even though we do our best, sometimes we fall short of some of these gold standards metrics of clarity, understandability, and actionability. And literacy is a big one, because the recommendation is to create resources at a 4th grade or lower reading level. And these, even though they were the top scoring of the educational materials we found, were still well above that goal of the 4th grade reading level, 7th grade in terms of the ResMed website, and then 10th grade reading level in terms of the patient-facing ATS resource. So again, bottom line, we have a lot, kind of a long way to go, especially in the case of OSA. In that study, we found that even the most highly scored and rated resources were falling short of the mark in terms of clarity and actionability. So leaving the question, how can we do better? So the next learning objective gets into some of the tools from my field, communication and health marketing, to help us think about how to frame health information, how to understand what our patients need. And hopefully the goal, of course, is to create clear, understandable, and actionable sleep health information. So before we get started, a few definitions. I'm admittedly learning a lot about the dissemination and implementation science worlds. They're a little bit newer than my background. Health communication is kind of an offshoot of social psychology. It's been around for decades, and the D&I area is this new, really cool area of research, and it does in some cases kind of draw upon health communication tools and techniques. So if there's anyone from D&I in the crowd, truly, I'm still learning about those fields and growing. But the focus of my talk is really my training and the work that I've done for the past over a decade on health communication. And that's defined by the CDC as the use of communication and marketing strategies. These are strategies that companies often use to sell products. I like to think of using those tools, but actually for good, for public health. So to inform and influence individual and community decisions that affect health. But just by way of definition, these are 2 for D&I research that I pulled. Dissemination science is the distribution of evidence-based interventions and materials to a specific audience, and implementation science is the use of strategies to adopt and integrate evidence-based health interventions and change practice patterns. So a lot of overlap. I really see almost these 3 as kind of Venn diagrams. And again, I'm kind of still learning about the D&I world, but in health communication, would it be fair to say, would you all agree that you can sorry, I'm jumping ahead. Let me back up. The health communication field is split into 3 kind of general domains. The first are public health campaigns. There have not been many in sleep, but the one of the classic and the recent big investments from the CDC in terms of public health campaigns in America was the one of the smoking campaigns recently, and it was all about former smokers speaking through narratives, through really compelling visuals, through voice boxes, telling their stories about their experience smoking and their kind of wish for others to learn and change when they didn't have the chance to do so. So some of them are very emotional appeals. Again, there haven't really been too many big scale health campaigns for sleep, but hopefully there will be. The second area of health communication research is interpersonal communication. That area of research often looks at the dyad of a patient and provider, or a kind of spousal communication as it relates to health. And the third is general health message design, and creating health materials that ideally are clear, tailored to a specific audience, and designed with thought and kind of rigor in terms of communication and marketing science. My work predominantly falls into that latter category of designing health messages and materials. So if you embark on an effort to change a behavior and you give someone a message, does that always elicit a thoughtful, logical behavioral change? The answer is, I hope you agree, not always. Rarely, maybe. If you have one message, does that kind of change someone enough, their belief pattern, to change their behavioral pattern? And it's hard because we are individuals and we are embedded within these kind of overlapping systems of culture, of social environments, of community factors, noise, sound in our environment, the social determinants of health, and then embedded within these systems of cultural values and personal values and knowledge level, attitudes towards behaviors, perceived risk of a behavior. If I think I'm vulnerable for at risk for sleep apnea, I'm going to think I'm, or be better able and motivated to get treatment. So social norms, are people around me supportive of my health journey? How, am I doing emotionally? Do I have social support for the behavior that I'm trying to recommend? And all of these things have a profound impact on our behavior. And so, of course, a single message couldn't be enough to change behavior. But when designed according to kind of communication and marketing science and principles, we can at least enhance our ability to change belief patterns and hopefully ultimately behavioral patterns. This is a very old school model from communication in the 50s called the Acme model. And I like this because it kind of spells out some of the levers of behavior change that you can use. First, it's just helpful to have an objective, identify a unique audience and a measurable and time-bound behavior. And the more specific and time-bound the behavior, the better. So whereas increasing sleep is extremely abstract, a better objective might be increased nightly sleep duration in teenagers. So then we have a specific goal, it's measurable, it's time-bound, nightly, and it's in a certain population. And then we can talk about what are the levers of behavior change to achieve that goal. And so if you're trying to understand the audience, you can survey your patients, your population in mind, and qualitative work is really powerful. I'm very much a mixed methodologist, to ask lots of questions of the people you're trying to reach. What are their barriers to their health behavior, and what are some of the solutions that they're seeking or considering? What is their kind of attitude or belief system as it relates to the behavior? We'll talk about that and how to think about that when you're crafting interventions. And then the last two buckets, when you're kind of at the stage of how do I design a message or an intervention, crafting the message can of course take a lot of different forms, and we'll talk about some of the trade-offs. Selecting a channel, give you some ideas. Is it social media? Is it a flyer? Is it a website? And then of course, evaluating your communication efforts are the three steps in this process. So again, understanding your audience is the very first step. Literature searches can be powerful here. Seeing what others have done in your population, survey your population itself, or closed-ended, asking questions about their beliefs, their attitudes, or open-ended questions. Polls or features on Instagram are also kind of helpful, actually. I kind of encourage people to think about social media as an opportunity to get reactions from your audience, if you're interested in kind of quick and dirty feedback, but of course, more thoughtful engagement with actual participants when possible, and also engaging multiple stakeholders. So not only the patient themselves, but sometimes it's really helpful to understand from their provider, the problem and the challenges, or a caregiver, et cetera. Behavioral theory is of utmost importance in this process to guide your efforts. There are a couple that I rely on in my research, and these are just a couple. There are more out there in the literature, but social cognitive theory, basically emphasizing the social environment and how important it is to have role models and kind of social proof when it comes to behavioral change. The second theory of planned behavior related to the upper right corner, the theory of reasoned action. The integrative model of behavioral prediction kind of combines the theory of reasoned action with the health belief model. I use the IMBP, integrative model of behavioral prediction, a lot in my work. Stages of change is also really helpful, thinking about where your person or population is when it comes to their readiness to change. And they have different kind of psychological beliefs and need different messages at different stages. Which is actually a perfect entree into this little example here about applying theory to create thoughtful, evidence-based behavioral interventions. The stages of change from Prochaska and DiClemente was pioneered in the area of smoking cessation, but I've applied it to sleep, and I think it's a really useful tool to understand where people are in terms of this psychological construct of readiness to change. So words or statements that a patient or a person or a population will endorse if they're at the pre-contemplative stage is, I don't have a problem. And maybe they don't know, or they don't even want to attend to their kind of knowledge about a problem or a risk. And so at this stage, it's really important to cultivate kind of a sense of discomfort among your patient population and emphasize the cost of non-action. So this is where maybe a fear appeal might be powerful, kind of focusing on the risks of non-action that can be motivational at this stage. The next stage, a patient will endorse the statement that I might have a problem. I've heard of that condition, that disorder, sleep apnea, and I might have it, and I'm maybe open to hearing more or learning more. And the communication that's necessary on the right-hand side, you see kind of what's necessary to move the person to the next stage. And this is kind of, you need to cultivate more discomfort than you did in the pre-contemplation stage. This is where kind of there's still hesitation. So helping people get over that hump, self-efficacy focused interventions can also be powerful. I will is a statement that someone would endorse at the preparation stage. That's preparing for change or preparing for action. And that's where an individual has decided to make a change. They're ready and willing, but there's something in their way. So you want to kind of understand what that is and focus the intervention on overcoming that challenge. The action stage is where someone is, maybe they've gone to their sleep provider or sleep specialist, they've gotten a diagnosis for OSA, and they are, they have a diagnosis maybe and haven't quite gotten the machine, or they're not adherent to their machine. So they're taking steps towards change, but they're not quite to the maintenance stage, which is where the sweet spot where we really want people to be, which is, I'm reaping the benefits of this change, I'm thriving, I have a plan, and I'm kind of staying on course. So the main message here is that this theory is powerful if you identify where a person is on that spectrum of readiness to change, then you can thoughtfully design your message accordingly. Another application of behavior theory to understanding challenges or kind of getting inspiration for messages to support a population as they kind of journey towards a goal. This is the integrative model of behavioral prediction I mentioned on the earlier slide about behavioral theories. This is what I use a lot in my work. It helps you kind of, first, you have to identify the target behavior. Again, the more specific and measurable, the better. The key thing in this theory and in the theory that kind of contributed to the development of this one, the theory of reasoned action, the intention construct is really important. So if a person has I like to call this kind of like a fuzzy trace idea, or like a fuzzy game plan to go to sleep at a certain time. For instance, if you're talking about maybe trying to get individuals to get into bed at the right time, they need to have a fuzzy game plan, a gist of a plan. And then cultivating that intention is really important, again, to support the subsequent behavior. And then that intention construct is predicted generally from 3 psychological antecedents. And the first is attitudes, and that's your generally a balance between your perceived benefits of the behavior. If it's healthy sleep, then I need to believe that I will feel better after, I will wake up refreshed, all those good things. And then I don't want to ideally hold any attitudes that would kind of position sleep as having any negative consequences. And then social norms is all about the people in my environment. And so participants will report on questionnaires that my friends think that I should XYZ, get 8 hours of sleep, get my sleep apnea treated, et cetera. So social norms really tap into this notion that others in your environment think you should do something, and would support you in that pursuit. The last is self-control or self-efficacy. They're kind of similarly referred to in the literature, and it refers to this notion that I believe in my ability to behave accordingly. So I believe in my ability to get sleep apnea treatment, insomnia treatment, et cetera. Now, the powerful thing about this model and what you're looking at here, this was one of my a paper a long time ago applying this theory to sleep health promotion strategies for teenagers or college students, I should say. So we did this exercise of mapping out these psychological antecedents to intention with the goal of developing a behavioral intervention. And what we did, these direct beliefs are kind of summary categories of psychosocial beliefs. But where this theory gets useful is it gives you kind of the tools to unpack the attitudes specific to the behavior that you're interested in. So let's talk about hypothetically this paper. It was understanding sleep of 8 to 9 hours in college students. So we asked lots of open-ended questions to tap into what's called the indirect beliefs that then comprise each of these buckets of beliefs, attitudes, norms, control. And so we asked students lots of questions, again, that contributed to these closed-ended questions that assessed very kind of at the root cause of attitudes, social norms, et cetera. And in the case of social norms, we asked questions such as asking students to endorse a belief that was phrased, I should sleep for 8 to 9 hours, or my friends think I should sleep for 8 to 9 hours. My parents think I should sleep for 8 to 9 hours. Or in the case of self-control or self-efficacy, the question was, sleeping 8 to 9 hours is easy for me. Or the other things that are related, we would ask questions like managing my time efficiently would allow me to get sleep. Those tap into the self-efficacy construct. And again, the reason that this theory in particular is useful is it goes kind of as far upstream as possible to understand the beliefs that people hold about a behavior. So you can apply this method to any number of different contexts. In this case, again, it was in the trying to understand why or why not students are or are not sleeping 8 to 10 hours at night. We did focus groups to ask a lot of those open-ended questions and then developed closed-ended statements that we then captured responses on Likert scales to then be able to comprehensively map out the beliefs that this group held. What you're looking at here is the regression looking at the relationship between these kind of discrete beliefs and then the intention construct. And the reason this is useful, you want to look for the beliefs that are really strongly associated with, positively associated, ideally with the intention to behave or the behavior itself. So for instance, injunctive norms weren't related to a behavioral intention here. So that's maybe not a belief to target in an intervention, if that's making sense. But instead, the attitude construct was really strongly associated with intention and with behavior, as were perceived behavioral control. And so that then is kind of a behavioral interventionist that gives me a sense that perceived control really matters here, and it might be a viable intervention target for the next phase, where I would then, go forth and design a message. And so that's just a little bit more. Again, this is the similar analysis of regression, but looking at the very discrete beliefs that then comprised that perceived control psychological construct. So very discretely, outcome expectations are part of the attitude construct. Injunctive norms, part of the social norm construct. Descriptive norms is the second part of norms. And then here are some of the enablers and barriers. Those are the two factors that contribute to the self-efficacy construct. And discrete beliefs that were highly associated with intention, were having less stress, would allow me to get enough sleep, and having time to managing my time efficiently would allow me to get more sleep. And so there, again, the beauty of this theoretical application is that you have discrete things that you can design messages, information, resources around for your target population, if you want to nudge and navigate them towards better sleep health. So coming back to the kind of pulling back the lens, the second step in the acne model is then crafting the message. And this is a question I get all the time. People will just say, so what is the perfect message? How do I, reach the population and capture their hearts and minds and change them? What's the message? What's the perfect formula? And of course, there is no one size fits all for messages. And this is where health communication and I believe behavioral interventions are a little bit of art and science because yes, we did go to the audience. Hopefully we've done some thorough formative and pilot work to understand the population, their belief systems, their norms, their attitudes, their self-efficacy. But then there is this kind of right brain aspect to, I believe, thoughtful behavioral interventions that really do, think creatively. How can we reach people? How could we maybe learn from what's going on in in popular culture right now? What are my target population? What are they interested? If it's adolescents, I mean, you've got to talk about TikTok because they're all on there. So we'll talk a little bit more about dissemination in a second, but really this idea of art meets science when you come to the intervention designs phase. But there is some theory to guide us on the message design, at least at the highest level. And I'd like to use an analogy of an onion when I'm talking about messaging, and basically thinking that at the very core of the onion is this evidence-based nugget of truth that is hopefully born from many, many studies that show that a behavior is good. In the most pure sense, we could probably, hopefully all agree on this meeting that sleeping 7 to 9 hours for adults is good. And it's almost hard to strip away value from a message or a frame or an angle. But if we just hypothetically say that's the evidence-based truth that you're trying to promote in a message, there are so many different layers that you can add if you're trying to achieve or spread awareness about that evidence-based nugget of truth. You could, for instance, take a gain frame. You could say getting 7 to 9 hours of sleep most nights will promote a positive mood. You wake up and feel refreshed and all of these other things. You could also say that you could also take a fear appeal. So you could also scare someone into getting enough sleep. If you don't get 7 to 9 hours, it places you at risk for car crashes or other scary outcomes. Another really effective mechanism for communicating information is narrative. And we'll talk about why in a moment. But then you tell the story about maybe a student named Jane, and she's on the varsity tennis team, and she sleeps 9 hours and she's the captain and she, received awards and yada, yada. So you kind of infuse the message with social cues. So a couple examples of what I call message heuristics, and those are basically the different frames or different ways that you package information in a sleep intervention. And the heuristic side on the left-hand side are just a bunch of different options. Perhaps the most boring is information only. If you just tell people, what a condition is, and it's, of course, that's important information, but maybe the most simple, just information only. And then you can think of each of these additional frames or arguments or kind of heuristics as other ways to communicate your information. Narrative, that would be taking a sleep health recommendation and putting it into the context of a story. So stories, of course, have characters and plots. So fundamentally, it would have to be a little bit longer. And hopefully there's, it's a nice package. A gain or loss frame. Again, you're emphasizing either the benefits or the risks of not doing something. Social norm appeal would be where you're, again, infusing information with social cues. And a fear appeal is where you're kind of scaring people into behaving accordingly by talking about scary things generally. So in the case of narrative messaging, there's a robust literature on narrative persuasion. And the bottom line here is that stories are powerful. We've been receiving this form of information in this form for, since we can all remember. Our caregivers would read us stories before bedtime. But what's so powerful about narrative in particular is you get immersed in the plot line when it's a well-written story, and suddenly you're being persuaded without even noticing or realizing it. So this concept of immersion in the story and kind of identification with the characters is really key to persuasion. I want to show you one video. I won't play the whole thing just because I'm running a little bit low on time, but this was for my postdoctoral work. I worked with Dr. Jean-Louis, Dr. Girardin Jean-Louis, who was at NYU at the time. He's now at Miami, just a wonderful health disparities researcher, as I'm sure many of you know. And he brought me onto his team for my kind of health communication expertise to help him design what he was calling the tailored approach to sleep health education. And so we designed a suite of materials for Black and African American individuals who were at risk for sleep apnea and who were untreated. And so we did formative focus groups, and it suggested that narrative might be a powerful approach. So I wanted to just play one of those videos for you.
I'm Kimberly Turner. I'm 54, and I'm from Brooklyn, New York. I've had sleep apnea for 7 years now. I had a very bad cold, and I've gone to the doctor, and I did began to describe some symptoms that I was having. And I mentioned to her also that I thought I had a postnasal drip because if I would lay my head down just to take a quick nap at work or something, I'd always wake up coughing, and it was terrible. So she gave me a referral for a specialist, along with some other medication for the cold. And I went to see him, and they evaluated me. I didn't go right away. You have to set up the appointment, so it was at least a week or two before I saw the doctor. Then they do an evaluation. Then, of course, they wanted me to come back to actually spend the night. And the thought.
And I'll just stop there in the interest of time, but this was a really powerful interview because you heard from Kimberly and her story, and she also, what was powerful in this video that really happened organically when we were interviewing Miss Turner was how it was like not easy, and there were some challenges that she faced, and she was uncertain, and that was a really important part of the message, actually, for other people to hopefully see this and think, wow, she looks like me, talks like me, she has similar struggles, it's not easy, but XYZ outcomes, improved. And so for all
I'm Kimberly.
reasons, narrative can be powerful. So the other mechanism or kind of heuristic is gain versus loss framing. Some of the formative work was done by President Peter Salovey at Yale and Dr. Rothman from his lab. Getting really close to doing my PhD with Dr. Salovey. He's done some really cool work on this topic of gain versus loss framing. And so basically this builds on prospect theory, Kahneman and Tversky's seminal work, and kind of distinguishes between a behavior that someone perceives to be risky or certain. Kind of the behavior that you're recommending will elicit an outcome that's either risky, unknown, or certain. So a lot of the work that has been done from their laboratory is in the context comparing kind of health detection where the outcome is uncertain or certain, and how loss and gain frame messages maybe differentially kind of support that person. One of the ways I think about this when we're talking about sleep health promotion is viewing sleep as breast cancer screening. The outcome is, again, uncertain, but in the case of eating a balanced diet or getting healthy sleep, we generally know that those things do elicit something beneficial. But what we're doing is we're also asking people to do things that are kind of additional to their day. We're asking people to add time to their sleep. And so I think really emphasizing a gain frame in the context of our work and kind of prevention and focusing or promoting healthy sleep, a gain frame can be a little bit more powerful than a loss frame. But then if you're thinking about sleep apnea detection or one of the sleep disorders that maybe is undiagnosed and a patient's not willing or motivated to do, a loss frame might be a little bit more important, talking about what they'll stand to lose if they don't change. Now, social norming, this is one of my favorite examples because it's one of my soapbox issues in sleep, but social norming refers to making compelling appeals that emphasize whether others are or are not doing a behavior. For instance, if I go, to my doctor and my doctor says, 90% of my patients are getting the COVID-19 vaccine, then that gives me social information on, wow, everyone is getting this. I should get it too. So I think one of the things that we do or could improve on in sleep is we often throw around the proportion of individuals who are non-adherent to CPAP. And what that does is it socially norms in the wrong direction and might actually exacerbate the problem. Because if we say, this is a problem and so many people aren't adherent, then that can limit patients and their ability to think, wow, this is something that everyone's doing, and so I should therefore as well. But flipping that around and instead maybe choosing a frame to talk about the benefit, a gain frame, or maybe a narrative would be maybe a little bit more appropriate. So fear appeals, the research on fear appeals has often been done in the context of smoking cessation. Graphical fear appeals are very common, required in some geographic areas to have graphic pictures of lungs or, something scary about smoking on cigarette packages. But basically fear appeals are messages that emphasize danger or harm. They can do so through emotion or visuals or language that could befall an individual if they don't adhere to the health recommendation. So in the case of sleep, for example, it would be failing to do your CPAP increases your risk for concerning cardiovascular outcomes such as heart attacks and strokes. The one asterisk with a fear appeal is that the literature shows without a shadow of doubt these are very effective, but they must be coupled with self-efficacy information. So supporting the person or the population with kind of a follow-up to say, this scary thing will happen, but the good news is treatment is easy. And so really emphasizing self-efficacy and people's belief in their ability after a fear appeal. Wanted to touch briefly. I'm not focusing this talk on my work on health disparities, which is a huge passion of mine and a big part of my research portfolio. But cultural tailoring is another tool in the kind of health communication toolkit. And it's basically the adaptation of the study design, materials, and other components of an intervention to reflect the cultural needs and preferences of a population. So I hope you can see just how powerful the mechanisms and the levers of change that we've talked about even so far, understanding the audience, adjusting information, thinking thoughtfully about frames, using behavioral theory. All of these are really powerful when we're thinking about reaching underserved populations or vulnerable populations, such as economically underserved communities, people, et cetera. Some other tools in particular that are useful for this effort of cultural tailoring that I focus on in my research are forging community partnerships, recruiting community champions and focus groups, and then having stakeholder advisory boards, people who can really meaningfully weigh in on your work. Okay, I'm just going to fly. I'm so sorry I'm going over. Just wanted to make a couple notes on the third piece of the ACME model, which is thinking about dissemination. How do I reach my population? We could think of personalization, how kind of personalized the message is, and then how many people I could reach with my message as kind of two trade-offs when you're thinking about disseminating and choosing mediums for choosing a medium for reaching a patient or a population. And you could think of the most hyper-personalized message is going to be interpersonal communication, probably with your doctor or a healthcare provider. And that, of course, is going to have a very low reach. So that's going to be the upper left quadrant here, whereas a public health campaign is going to be very low on personalization. We're going to have to develop that message, in the office and do our best to create it to, speak to as many people as possible. But then you lose a lot of control as you release a public health communication message or a public health campaign, like the one we talked about earlier. So thinking about this continuum of personalization and reach, and of course resources that would be necessary is one kind of continuum I like to think about. And then options along the spectrum are peer-to-peer communication, digital technologies. Is an app always good? I feel like people always just say, let's make an app. Not necessarily. In some cases, yes, but not always. Social network interventions, and then print materials. And then some questions that you might consider asking your audience when you're trying to choose mediums are really going to your audience and trying to figure out, where do they get their health information? What do they like receiving information on? It's not always the best question, where do you get your health information? But it's kind of like, where do you spend your time? Are they on TikTok for an hour? I mean, that might be a good place to reach them. Or are they, do they love the New York Times? So thinking about how people are consuming information and how to get on their radar. And then evaluation, of course, this goes without saying, but evaluating your health communication intervention is, of course, key. But thinking thoughtfully about how an intervention or a message is kind of impactful. And there are sometimes more creative than I think we realize, ways that our message, our information impacts people. The direct exposure is, of course, was the message read, opened, processed, evaluated? Then psychosocial changes could be, did the message change my belief system? Do I now have a stronger intention to perform the behavior? And then, of course, the actual behavior itself. So sorry to just keep cruising through, just a little short on time. The last learning objective is a case history of applying health communication tools to promote sleep apnea. So just a little case history from my work on applying this toolkit of communication science. So developing a text messaging intervention for shift workers. I don't need to tell this crowd how concerning shift work is. 25 million Americans are shift workers due to the challenges on the right-hand side. Shift workers face profound sleep difficulties compared to day workers, longer sleep latency, shorter sleep duration, more daytime dysfunction. And there are consequences, unfortunately. Shift workers face a 4% increase for cancer and mortality and 15% for cardiovascular mortality risk. And all of these challenges combined led the IARC to deem shift work not a possible but a probable cause of cancer. So let's talk about the population that I studied for my the beginning of my K award. These are highway maintenance workers in the U.S. Northeast. They drive snowplows really around the clock. If you many of you here in New Haven, us certainly in Boston, this is how we wake up after a snowstorm and our roads are clear. So we have a huge debt to this population. They're very low income. They're 30% were earning less than $50,000 in terms of annual income. And our pilot data revealed that 70% of drivers scored moderate or high risk for sleep apnea, but only 16% reported a diagnosis. So that's reflected here. We saw 14% had diabetes, 42% hypertension, 10% depression, and then pretty high scores on the Epworth sleepiness scale, and then OSA risk here. 6% were very high risk 48%, and low risk 18. So a population that really was kind of needing this intervention on sleep apnea. The goal with this project was to design a tailored sleep text messaging intervention for increasing adherence to OSA evaluation and treatment in transportation workers. The intervention delivered text messages, building on our qualitative work. We found that this is just a very hard to reach population. There's very little time in the office or the work site, but they really just get in their trucks and go. The time when they're powering down at nighttime seemed to be a real teachable moment. So we thought text messages delivered around bedtime or that person's sleep approximate onset period might be beneficial. Then we did include components of message tailoring because it was a text message that was going out. Individuals, we could tailor the information that we were sending to each recipient. And we use the stages of change model to do that, and hypothesizing that if we model kind of match OSA to the stages of change model, that those in the denial phase might have no intention, contemplation, maybe they know about the disorder, but they're not doing anything, preparation, they might be planning to get an overnight sleep recording done, action, they're using their CPAP, maintenance, they're, treated, adhering treatment, etc. So we designed this intervention in 3 phases. My work is almost always kind of multi-level. The first, we did focus groups with drivers and managers to identify the barriers and facilitators to OSA care. In the second phase, we analyzed the qualitative transcripts and developed some key messages. And then in the third, we did a very small pilot RCT for this award. So phase 1, we did some interviews, we contacted drivers, and I sat down, did a number of focus groups with them, talking about some of these barriers to awareness and treatment. Some of the focus group themes on sleep broadly were real challenges, kind of unwinding and relaxing as they come off shift. They're exhausted, but also wired. They come home because they're, white knuckling in a snowstorm, down the highway, fighting to stay awake, and then they get home and they're on high alert and can't unwind. So we talked a lot. They talked a lot about difficulties unwinding. Really interesting. They all I have a quote from almost every single driver of this witching hour, they called that period, and when the sleep drive is so strong right before their kind of otherwise habitual bedtime or rising time, right before the sunrise in the morning, was when they reported that's when most of the accidents happen, when they really struggle the most with this stuff. So those were some of the sleep related themes. And the OSA themes, there's a lot of misinformation. They reported a lot of knowledge and awareness of very late night sleep apnea infomercials and gadgets and gizmos. They had a lot of questions about those. If a mouth guard would be enough. So it sounded like there was an opportunity to really promote awareness and evidence-based knowledge in this population. Snoring was very common, and beliefs about snoring we found to be that, it to not really be a big deal was kind of what emerged. We did find a couple bright spots in the population, success stories of people that were, seeking their treatment and doing well. I'm so sorry. I'm just going to cruise because I want to leave some time for questions. Those themes then led us to a couple key messages for this intervention. We did incorporate meditation for assisting with some of these difficulties unwinding, combating dysfunctional beliefs, promoting treatment knowledge, and then success stories. So we developed a website where it was interactive, but it also was accompanied by these tailored messages that went out to users. I don't have time for this. It's another
So
wonderful
I got
video.
tested.
This is a manager at the Department of
I've snored.
Transportation.
So I
He
got
used to be a driver. I'm so sorry I can't do the whole thing, but he was a wonderful case history, got treated for sleep apnea, and talked about some of his successes. So the text message nudges were sent out. They were designed according to the individual person's readiness to change. And so thoughtful changes to the text itself were made based on the readiness to change stage, with the idea of nudging and navigating people ever increasingly closer towards better sleep apnea awareness, care, etc. This is what one of the text messages looked like. As you can tell, we use the kind of bedtime for this person as a teachable moment around 8:01. Text messages went out. There was a little brief tailored message, and then it linked out in some cases to the videos that we filmed. We did a mini RCT, very small scale pilot study to look at the result of exposure to this intervention in workers. So there's a 30-minute in-person kickoff education followed by text messages and narrative videos. At time 0, we randomized work sites, baseline surveys went out, the intervention site received the program, and then there's a 2-month follow-up. Then very small scale. So we did 20 employees in the control, 18 in the intervention. The primary outcome was OSA self-efficacy and literacy. We also measured daytime sleepiness. Additionally, attentional failures, and then overall readiness to change. We analyzed the data and we did between group differences on primary outcomes at 2 months using linear regression with the outcome at baseline as a covariate and the randomized group as the dummy to compare the two groups. This was the demographic breakdown. The primary outcomes, these are just means and standard deviations. Not a huge shift in OSA self-efficacy, a slight increase overall in the treatment condition you see from 0.4 to 0.6, but these aren't huge jumps. This is, again, a very hard to reach population. There are also some barriers to commercial drivers. Some of you may be familiar with these. For a lot of reasons, we realize that we have to temper our enthusiasm when we're working with a population like this, but we were very excited to see one significant outcome in terms of OSA literacy increasing as a result of exposure to the intervention. As we talked about, that is, of course, a very important antecedent to change, just knowing the parameters of this disorder, the symptoms, treatment, et cetera. So sorry, I don't have a little bit more time. Our secondary outcomes, the readiness to change, we did see a slight progression here, which was exciting, but we did see also a slight increase in the control conditions, so not sure quite how to make sense of that, but we did see a nice reduction also here in the treatment condition, also in the control, but not quite as steep a decline. The regression analyses of the additional outcomes also did not find a significant change, but perhaps maybe a trend towards improving readiness to change. Just a huge shout out. I have a wonderful group of trainees that I mentor, and I'm very proud of. They've all contributed to this work. I'm also part of this terrific team led by Dr. Charles Seisler. I work really closely with Dr. Kwan and Laura Barger and Matt Weaver, and these are our wonderful program coordinators. So I'm so sorry. I have 2 minutes for questions. I went way over. I'll pull out my slides now.
Great. Thank you very much, Dr. Robbins. I really appreciate this wonderful talk. What a really tour de force introduction to behavior change and messaging. And so we do have just a couple of minutes, and then Dr. McNally does have a question for you about direct-to-consumer advertising for healthcare. And in particular, his question is about the Inspire therapy, and it's a recent push to consumer advertising. And so do they serve a positive function, or should professional societies take some steps to, regulate them in some way?
That sounds like an opportunity maybe for an ASM or SRS conversation. That is such an interesting and great point. I've heard so many reports of just knowledge of those advertisements, and in some way, if they're thoughtfully designed and maybe designed with input from a scientist or a specialist, that they could be overwhelmingly positive. They have big bank accounts. They can, do huge campaigns. And if they're promoting awareness about sleep apnea, then I'd call that a win. But if they're, at all kind of fostering ideas of, this being the only treatment and confusing patients, I think that would be a very big loss. But I think that's a great idea actually for something to study, to see how that's impacting patients and individuals.
Yeah, thank you. And I have a question for you, specifically about the different heuristics used in messaging. And, for many of us who practice in a clinical space and office, what would you say would be, top 2 or 3 messaging strategies or heuristics to use in that setting to educate people about sleep apnea risks, and then maybe about their self-efficacy, and then the benefits of CPAP therapy?
Great question. I mean, you might think of some of the behavioral theories we talked about today, and I think the patient-centeredness and qualitative conversations, opportunities to ask lots of open-ended questions, all of that good stuff could give you really valuable input that might raise a flag of like, oh, I think this is a self-efficacy problem. And then supporting self-efficacy is all about making things, breaking them down. you know, you can do this, supporting someone's belief in their ability or the treatment benefits that you could get from a therapeutic intervention. So I think kind of keeping your eyes and ears peeled in the encounter for any guidance on, what might be a powerful lever of change, but also thinking of the encounter as kind of a little mini test kitchen where see if the self-efficacy approach flies. And then if it falls flat and the patient's like, oh, no, and it's clearly not working, then maybe change your tact and think, might it be a gain or loss frame question or conversation? And then if you get any social cues, if someone chimes in and says, I don't think this isn't going to fly with my partner, or, no one in my friend group has one of these. You could say, oh, I have XYZ patient. If you could call on a case where maybe there's an instance where someone was a trailblazer, they were the first in their family, and then they, helped promote awareness in the other members, then that could be a valuable social norm intervention.
Very cool. Excellent. So if anybody else has questions, please raise your hands. And I guess until that happens, we're actually close to overtime. So
I'm so sorry.
oh no, this was great. This was great. And so if people have questions, what would be the best way for them to reach you?
Yes, email. I will put that in the
Okay,
chat.
great. Well, thank you very much, Dr. Robbins. It was a pleasure having you here. I
Thank you,
apologize I wasn't
Dr. Vinchuk. Thank you for
able to
having me. It's
introduce
great to
you right
see you. Hope
at
to
the
see you in
moment, but
Houston.
absolutely. Okay,
Have a
take
great day.
care.
Take care.
Bye-bye, everyone.